All right, guys, good evening. All right, so let's do a couple of important topics which are going to be from our INI-CET exam. Again, the systemic part we'll try to decode in the form of radiological aspects, and then we'll try to build up from there. Now, the first spotter that you can get is going to be like this. You can see there is a radiograph. You can see there's a Ryle's tube that is getting coiled inside, right? Now, if I say that we have a baby who is now presented at day 0, day 1 of life, the complaint is regurgitation of all feeds and there's continuous drooling of saliva. By now, you would have already gotten the diagnosis. The diagnosis for this condition is going to be tracheoesophageal fistula. The diagnosis of this condition is going to be the tracheoesophageal fistula. The diagnosis for this condition is going to be the tracheoesophageal fistula, right? Now, if they ask you what is the investigation of choice for the tracheoesophageal fistula and atresia, that is going to be contrast imaging, and the safest contrast that you will get is going to be iohexol, which is an iodinated contrast. Now, if iohexol is not given in the option, right? So the most common is going to be the iohexol. In fact, the iohexol is also considered to be the best contrast medium that is available, right? Now, let's say if the iohexol is not given in the option, what is the next contrast that you can give? You can also give the dinosol. The dinosol is another contrast that you can actually give. The most common type is going to be type C variety. I hope everybody remembers. The type C, there is atresia with lower communicating tracheoesophageal fistula, and the congenital anomalies that it is associated with, it is going to be VACTRAL. So when I say VACTRAL, V stands for vertebral body defect, right? A stands for anorectal malformation. C is your cardiovascular abnormality, example like patent ductus arteriosus or ventroseptal defect. T is your tracheoesophageal fistula. R is your renal abnormalities, and L is your limb abnormalities. Now, if they want to make your life a little bit difficult, they can ask you that what is the criteria used for treatment. Criteria for treatment in the tracheoesophageal fistula. The criteria for treatment in the tracheoesophageal fistula is what we call it as the Waterson criteria. It is what we call it as the Waterson criteria. This is what we call it as the Waterson criteria, right? So in the radiograph, what are you able to see? In the radiograph, I am able to see coiling of nasogastric tube. This is the coiling of nasogastric tube. All right. The next spotter that you can see that there is this mucosal narrowing which is present in the upper part of the esophagus. Now, if you have the mucosal narrowing in the upper part of the esophagus, this is going to be an upper esophageal web. Now, in which condition do you see in the upper esophageal web? The upper esophageal web is usually seen in Plummer-Vinson syndrome. The Plummer-Vinson syndrome is also commonly referred to as the Patterson-Kelly syndrome. It is also associated with the Patterson-Kelly syndrome. So what are the components that it is actually associated with? Now, when you look at this, it is associated with number 1, atrophic glossitis. Small correction here. It is atrophic glossitis. Upper esophageal web. Koinonchia, that is the nail deformity, and visceromegaly. So the conditions which are associated with the Patterson-Kelly syndrome, number 1, it is associated with the atrophic glossitis, upper esophageal web, koinonchia, and the visceromegaly. Now, when I say where do you see the lower esophageal web, you can see here the lower esophageal web is seen as, or also known as, the Schatzki's ring. Remember, it is post-GRD. You can see in the post-GRD, this is mucosal adhesions. The post-GRD mucosal adhesions which present to you as web, but because the GRD reflux occurs in the lower part of the esophagus, they will be in lower 1/3 of the esophagus, and that is what we call it as mucosal. Basically, the signy case, no, they present to you as like web, right? Now, what is this spotter? When you look at this spotter, it is again a beautiful analogy. It's a beautiful analogy where you can see that this is the apple, and somebody has eaten the apple and thrown the core out. So this is what we call it as the apple core sign. Now I hope everybody knows that apple core sign is seen in the esophagus. If you have the apple core sign, it can be because it's only because of exuberant growth that occurs within the esophageal lumen. This is because of the exuberant growth that occurs in the esophageal lumen. So the apple core sign is seen in esophageal cancer. This is seen in esophageal cancer. Another sign that you can see here, you can see this hunch that is created. That is what we call it as the shouldering sign. That is what we call it as the shouldering sign. That is what we call it as the shouldering sign, right? Now, so what are the findings that you have? Number one, you can see on a barium swallow, there is a shouldering sign. Apple core sign in the esophageal cancer. Now, when you talk about rat tail, see rat tail can also be seen. So, if you talk about what are the signs that you see, number one is shouldering sign. Number two will be your apple core sign. There will be this apple core sign that you will see. Rat tail sign can also be seen, right? Now, if I say what is the most common type, right? The most common type is the squamous cell carcinoma. The most common type that you can see is going to be the squamous cell carcinoma. The most common type is going to be the squamous cell carcinoma. It is going to be the squamous cell carcinoma. It is a squamous cell carcinoma. Now, the most common site that you will see, the most common site will be the middle 1/3 of the esophagus. When we talk about the site, the most common site is going to be the middle 1/3 of the esophagus. So I say the overall most common is going to be squamous cell carcinoma. It is a squamous cell carcinoma. Now, remember the name of the surgeries that are done for the esophageal cancers. The name of the surgery is Ivor-Lewis surgery. Ivor-Lewis is a 2-phase surgery. McKeown's is your 3-phase surgery. McKeown's is a 3-phase surgery and Oringer's is another 2-phase surgery. Currently, the surgery of choice for esophageal malignancies is your Oringer's transhiatal esophagectomy. The complete name is your Oringer's transhiatal esophagectomy. Oringer's transhiatal esophagectomy, right? So this is with respect to your shouldering sign. Now, when you look at this spotter, you see there's an outpouching which is present in the cervical region of the esophagus on the posterior side. And this can only be your Zenker's diverticulum. This can only be your Zenker's diverticulum. So Zenker's diverticulum is an example of a pulsion diverticulum. It's a false diverticulum. The most common site is going to be cervical esophagus on the posterior side. The anatomical weakness is going to be the Killian's dehiscence. And the most important clinical feature that you will see will be regurgitation of previous day food particle. It is regurgitation of your previous day. It is the regurgitation of previous day food particle. It is a regurgitation of previous day food particle. See, we all have regurgitation, but in the exam, if you see a question which says regurgitation of previous day food particle, that is only going to be possible with Zenker's diverticulum. Now, in the barium swallow, you will have a pouch-filled barium. A pouch-filled barium is noticed. If it is less than 3 centimeters, if it is going to be less than 3 centimeters, then you do a diverticulectomy. But if it is more than 3 centimeters, if the size of the diverticulum is more than 3 centimeters, then you do an endoscopic Dolman surgery. Then you do a endoscopic. Then you do an endoscopic Dolman surgery. The endoscopic Dolman surgery. Now, this is another spotter. Just to give a perspective, let's say this is day 0 or day 1 of life. Right? So this is a baby who is now presented to you. The baby's presentation is of RDS. There is respiratory distress. There is respiratory distress. There is dextrocardia. There is dextrocardia and there is scaphoid abdomen. There is a scaphoid abdomen. So there is respiratory distress, there is dextrocardia and there is scaphoid abdomen. The respiratory distress, dextrocardia and scaphoid abdomen is the presentation, right? Okay. Now, when you look at the radiograph, you see there is a massive air bubble. So, there is this massive air bubble in left hemithorax. In left hemithorax. Along with that, you see the heart border shifted on the other side. There is dextrocardia. There is presence of dextrocardia. There is presence of dextrocardia. And you can also see the trachea is also deviated onto the opposite side, telling you it's a pressure effect. And this is seen in Bosch-Dallek hernia. This is seen in Bosch-Dallek hernia. This is seen in Bosch-Dallek hernia. Now, the only question that they can ask you, again, it's an important topic from the exam perspective. If they ask you in Bosch-Dallek hernia, they'll ask you where is the defect. The defect is going to be left-sided. When you say the defect, it is left-sided posterolateral. It is a left-sided posterolateral defect. It's a left-sided posterolateral defect. This is the upper GI endoscopy. In an upper GI endoscopy, you can see this is the image that is present. The image is of salmon colored, or also called as the red velvety mucosa. Now, when you talk about red velvety mucosa on an upper GI endoscopy, then the diagnosis goes in favor of Barrett's esophagus. It is going to be in the favor of Barrett's esophagus. What is the investigational choice for Barrett's esophagus? It is our upper GI endoscopy with biopsy. Barrett's esophagus increases the risk for adenocarcinoma of the esophagus, not squamous cell, that's important. It is the adenocarcinoma of esophagus. It is the esophagus. But a CMV will have erosions. There is no erosion, there is only metaplasia that you can see. Redness has been clearly evident. Now, in Barrett's, what type of metaplasia that you will see? Remember the type of metaplasia. The type of metaplasia that you will see in Barrett's is going to be intestinal type of metaplasia. It is the intestinal type of metaplasia. It is an intestinal type of metaplasia. It's an intestinal type of metaplasia. Another very interesting and important question that they'll ask you in the exam is about the neonates with recurrent vomiting and how do you move forward with this, right? Now, when we talk about the neonatal vomiting, we'll see the age of presentation, the type of vomitus, and that is going to tell us about the diagnosis. Now, if you have a 4th week baby, right, there is projectile vomiting. There is projectile vomiting. There is this projectile vomiting, and this is non-bilious. There's a projectile vomiting and it is non-bilious. On an image, you see there is a single bubble sign. On an image, you see there is a single bubble sign. What do you think is the diagnosis? A 4th week old baby, I'll just make it even more easier for you. Imagine that this baby is a male child. Imagine this baby is a male child, right? So, male child with projectile vomiting, non-bilious in nature with single bubble sign. So, what is the diagnosis? The diagnosis here is the congenital hypertrophic pyloric stenosis, and the management is surgery, and the surgery of choice is going to be Ramsted's. It is the Ramsted's pyloromyotomy. It is your Ramsted's pyloromyotomy. It is your Ramsted's pyloromyotomy. Okay? Sure. Yes, it is because of, prenatal, I would say erythromycin consumption by mother, olive lump, visible peristalsis, all the pathognomic stage. Okay? Sure. Coming back here, on day 0, day 1, if the baby has vomiting which is non-projectile. We have a non-projectile vomiting, but this time you have a bilious vomiting. And this is the radiograph. In this one, you can see the gastric bubble, another one is duodenal bubble, and this is what we call it as the double bubble sign. This is what we call it as the double bubble sign. Now, the double bubble sign, when you talk about what is the diagnosis, it is going to be duodenal atresia. It is going to be duodenal atresia. Another condition that you can have this double bubble is your annular pancreas. It is your annular pancreas. The management is going to be surgery, and the surgery of choice is going to be duodenostomy. There's a duodenostenomy, right? For both of them. But if I say what is the investigation of choice, just for the sake of completion, for duodenal atresia and annular pancreas, if they ask you what is the investigation of choice, then it is going to be the contrast CT of the abdomen. Okay. Chal. Coming back to our third presentation that you have, day 0, day 1. Again, imagine there is a non-projectile vomiting. There's a non-projectile vomiting. It will have a bilious vomiting. Now, when in the bilious vomiting, this is the gastric air bubble, this is a duodenal one, this is jejunal. So there are 3 bubbles. So it is what we call it as the triple bubble sign. This will have a triple bubble sign. Now, the triple bubble sign is going to be your jejunal atresia. It is your jejunal atresia. The management for jejunal atresia is going to be surgery, and the surgery of choice is going to be jejunostomy. It is going to be your jejunostomy. This is going to be your jejunostomy, right? So all 3 neonatal vomiting, their radiographs and their management is been your previous exam question. We have summarized in one particular table. Now, coming back to the peptic ulcer disease. In the peptic ulcer disease, out of duodenal ulcers and gastric ulcers, which is more common, the answer is duodenal ulcer. The site of the duodenal ulcer is the first part of the duodenum. That is the most common site. And the site of the gastric ulcer is going to be the antrum of the stomach. The antrum of the stomach is on the lesser curvature. On the lesser curvature of the antrum of the stomach is the most common site for gastric ulcers. The ulcer environment in a duodenal ulcers is going to be hyperacidic. It is hyperacidic. For gastric ulcers, it is either normoacidic or it is hypoacidic. It is the normoacidic or hypoacidic. Duodenal ulcer will have pain, which is usually milder in nature and occurs after 2 hours of consuming food. Gastric ulcer, the pain intensity is more severe, and this is your immediate food pain. This is your immediate food pain. This is your immediate food pain. The appetite in the duodenal ulcer increases because it's a milder pain, and the appetite in gastric ulcer reduces significantly. Now, if the appetite increases, there will be weight gain in duodenal ulcer and weight loss in gastric ulcers. Now, the risk for hemorrhage is more with respect to your gastric ulcers. The risk for perforation is more with your duodenal ulcers. Duodenal ulcers can never be pre-malignant. Your gastric ulcer usually pre-malignant. They increase the risk for adenocarcinoma of the stomach. For duodenal ulcers, it is only upper GI endoscopy is the investigation of choice. But when you're doing a gastric ulcer or you find a gastric ulcer on upper GI endoscopy, the biopsies are must. So upper GI endoscopy with biopsy. Upper GI endoscopy with biopsy becomes the investigation of choice. Becomes the investigation of choice. Now, every patient of peptic ulcer disease will have some association with H. pylori. So how do you know, right? Now, the first one, if I say what is the investigation of choice for H. pylori? The investigation of choice is the urease assay test. Now, this urease assay test is also commonly referred to as the CLO test. It is also called as the CLO test. So, what is a CLO test? It is a Campylobacter-like organism test. It is a Campylobacter-like organism test. It is the Campylobacter-like organism test. On the other hand, you have histology, which is the other one. But if I say what is the best investigation, see, for all bacteria, you cannot beat the culture. So culture becomes the best. Which investigation will tell you about the response to treatment, whether it is working or not? The answer is your breath urease test. It is the investigation of choice for assessment of treatment response. It is the investigational choice for the assessment of the treatment response. Which is the most cost effective? Remember, the most cost effective test. The most cost effective test is your stool antigen test. It is your stool antigen test. You can also do serology, but whatever I've written in red is your exam question. Okay? Now, in order to assess up H. pylori, remember, PPIs must be stopped at least 2 weeks before the assessment, and all antibiotics, if the patient is consuming any form of antibiotics, they must be stopped 4 weeks prior to the investigation. So H. pylori assessment, whenever you're doing it, stop PPIs 2 weeks before and antibiotics 4 weeks before. The management, we all know it is going to be either a triple therapy or a quadruple therapy. Now, most of the things are same in triple and quadruple. In quadruple, we also take care of the pain. So, in the triple therapy, you have the proton pump inhibitors, clarithromycin with amoxicillin or metronidazole, right? In quadruple therapy, what are we adding extra? We are adding bismuth. Bismuth is ulcer protective. Bismuth is ulcer protective. Now, another important topic is going to be gastric carcinoma. In the gastric carcinoma, when you talk about risk factors, the nutritional risk factors are important from the exam perspective. Number one is low fat or low protein diet. Second one is the salted meat and the high nitrate consumption. These three are the principal ones. In the environmental risk factor, anything that predisposes or increases the risk for H. pylori. Increases the risk for H. pylori. Now, things that can increase the risk for H. pylori is poor food preparation, lack of refrigeration, poor drinking water. Poor food preparation, lack of refrigerator, and poor drinking water are the risk factors. All right. Now, what are the medical causes? The medical causes, all previous gastric surgeries can predispose to gastric carcinoma except for highly selective vagotomy. Except for highly selective vagotomy. The other ones that you can see is going to be one bacteria and one virus, H. pylori and Epstein-Barr virus. These are carcinogens, right? Atrophic gastritis, specifically, let it be both type A or type B, both of them. Atrophic gastritis, let it be type A gastritis or type B gastritis. Both of them will result in atrophic gastritis, results in gastric carcinoma. On the other hand, if you have a male sex and low socioeconomic status are the adjuvant one, but whatever I've marked it, they are your previous exam questions. Now, in the clinical features, what you have to remember is the difference between the proximal gastric malignancy, versus the distal gastric malignancy. For the distal gastric malignancy, right? So proximal gastric malignancy versus distal gastric malignancy. Remember, in proximal gastric malignancy, patient will have dysphagia with dyspepsia, dyspepsia with upper GI bleed. In distal gastric malignancies, the patient will have gastric outlet obstruction with upper GI bleed. And this is what you have to remember. So if it is dysphagia dyspepsia with upper GI bleed, it is most likely to be your proximal gastric malignancy. For distal, it is going to be gastric outlet obstruction with upper GI bleed. Now, in an atypical presentation, this is what you have to remember. If there's an enlarged left supraclavicular group of lymph node, that is nothing but your Virchow lymph node. Involvement of Virchow lymph node is what we call it as the Trozier sign. This is what we call it as the Trozier sign. Irish group of lymph nodes is your enlarged. They are your enlarged left supraclavicular lymph node. Enlarged left supraclavicular group of lymph node. Sister Mary Joseph group of lymph nodes is your periumbilical. It is your periumbilical group of lymph node. It is your periumbilical group of lymph node. Krukenberg's tumor is your ovarian. It is your ovarian drop metastasis. It is your ovarian drop metastasis. Blummer shelf is your pelvic deposits. The pelvic deposits are basically pelvic secondaries. The pelvic deposits are your pelvic secondaries, right? So Blummer shelf, remember, it is appreciated on a digital rectal examination. This is appreciated on a digital rectal examination. This is appreciated on a digital rectal examination. Now, two atypical findings that you can see in as a skin lesion. Number one is what we call it as the lesser Trullat sign. This is your lesser Trullat sign, is a multiple seborrheic keratosis. It is multiple seborrheic keratosis. And this is your tripe palm sign. Scaly palm, this is a tripe palm sign. This is basically your scaly palms. So here it is going to be hyperkeratotic palm. This is your hyperkeratotic palm. Both of them are seen in the gastric carcinoma. The good thing about it, it is reversible. This is going to be reversible. Now, in terms of investigation in the carcinoma stomach. Now, upper GI endoscopy with biopsy is the investigation of choice for diagnosis. It is the investigation of choice for diagnosis. Endoscopic ultrasound is the investigation of choice for T staging. CT is going to be the investigation of choice for loco-regional spread. For the loco-regional spread. PET CT is the investigation of choice for distant metastasis. For your distant metastasis. Staging laparoscopy is to evaluate peritoneal seeding. See, there is no investigation which can actually tell whether the peritoneal seeding is done or not. Again, a very important one. If the peritoneal seeding occurs on the gastric cancers, it is going to be inoperable. It is not recorded beta. If you have question, you can definitely ask. Okay. So these are all the high yield points in terms of gastric malignancies. Clear? Sure. Now, in terms of few other components in the malignancy, the stomach only, there's a small misprint there. What is a Mallory-V stare? The Mallory-V stare, if you talk about it, it's a submucosal tear. It is a submucosal tear. If I ask you a question, right, in this submucosal tear, What is the most important risk factor? The most important risk factor is repeated vomiting. The most important risk factor is going to be repeated vomiting. Okay. The most common site is going to be the cardia of the stomach. It is the cardia of stomach. It is the cardia of the stomach. Management, or I can say investigation of choice, because they present as upper GI bleed, it is your upper GI endoscopy. Management for Mallory Weiss tear, it is self-limiting. It is self-limiting. Treat the underlying cause. If there's an active bleed, yes, you can go ahead and do an electrocautery, otherwise not required. Next, you have 𝐾𝐝, that is your gastric antral vascular ectasia. Remember, it is also known. The only question that they'll ask you, what is it called as? It is called as the watermelon stomach. This is what we call it as the watermelon stomach. This is what we call it as the watermelon stomach. This is defined as watermelon stomach. It is basically a vascular ectasia. It is a vascular ectasia. The clinical presentation for 𝐾𝐝 will be your upper GI bleed. It will present as upper GI bleed, and the management is going to be electrocoagulation. It is going to be electrocoagulation. So in the exam, they'll ask you about this, right? So this is going to be the image that you have to focus on. It's the watermelon stomach. Clear? Clear? What liver, beta? क्या liver है? The most common site for secondaries is liver, beta. If you are asking what is the most common site for secondaries in carcinoma stomach, then the answer is going to be liver. So entire GIT, because of portal circulation, will spread to liver. ठीक है? When I say staging laparoscopy, आप क्यों करते हो? Staging laparoscopy आप इसलिए करते हो to see for peritoneal deposits. क्योंकि अगर लिवर में कोई लीजन है वो तो सीटी पिक कर लेगा, बट पेरिटोनियल लीजन्स दे वेरी डिफिकल्ट टू पिक ऑन सीटी आल्सो, राइट? सो हेंस वी डू अ स्टेजिंग लैप्रोस्कोपी. चलो, now two conditions which are going to be repeatedly asked in the exam. Two conditions which are repeatedly asked in the exam is going to be your intersusception and volvulus. The basic concept of intersusception is if the proximal end of the bowel telescopes into distal end, resulting in dynamic bowel obstruction. Resulting in dynamic bowel obstruction. Resulting in dynamic bowel obstruction. Resulting in dynamic bowel obstruction is what we call it as intersusception. Volvulus, on the other hand, if a loop of intestine, if the loop of intestine rotates around its own axis. If the loop of intestine rotates around its own axis. If the loop of intestine rotates around its own axis, again, this will also result in dynamic bowel obstruction. This will also result in dynamic bowel obstruction, is what we call it as volvulus. Correct? Now, in the images, what are the findings that you see? In intersusception, you will have the claw sign. So, on the barium enema, there will be presence of claw sign. If I say what is the investigation of choice for intersusception in children? Investigation of choice in children for intersusception is ultrasound. On an ultrasound, the finding that you can see is two things. Number one, you will see this presence of target sign. Number one, there will be target sign. And what is the second one? You can see, so this is your target sign. So this everybody can recognize, no problem. What is this sign? The other one that you can see is going to be a linear projection that you see. This is your pseudo kidney sign. This is your pseudo kidney sign. This is a pseudo kidney sign. On the other hand, if I say what is the investigation of choice in adult, the investigation of choice in adult is going to be CECT abdomen. So for all intestinal obstruction, it is going to be CECT abdomen. On the other hand, if you look at in terms of volvulus, in a volvulus when you perform an X-ray, it is going to be the coffee bean sign. This is going to be the coffee bean sign. Now, when you look at this coffee bean sign, what volvulus do you think it is? Is it a sigmoid volvulus or a cecal volvulus? Now, if the coffee bean is pointing towards the right upper abdomen, this is the right upper abdomen. If the coffee bean is pointing towards the right upper abdomen, then it is going to be your sigmoid volvulus. And if it is pointing towards, you can see here, it is pointing towards, this is the entire coffee bean that is formed here. If it is pointing towards, the left upper abdomen, then it is your cecal volvulus. Then you see there is on barium enema, it appears as a bird is waiting to catch its prey. On a barium enema, this is also called as the bird of prey sign. This is what we call it as the bird of prey sign. Okay? How do you manage? See, both intersusception and volvulus are equally tricky. So the management varies between child and adult. In child, when you talk about in intersusception, the first is going to be enema. So when you give enema, we give 2 attempts of air enema. We have 2 attempts of air enema, then the last attempt is barium. So there are 3 attempts of enema should be given. If this does not occur, then if it is not resolved, then take the patient for exploratory laparotomy. In adults, there is no role for enema. We directly take it for exploratory laparotomy. In volvulus, the first line of management is going to be colonoscopic detorsion. Now, if the colonoscopic detorsion fails, then we take for exploratory laparotomy. We take the patient for exploratory laparotomy. Now, when you're taking the patient for exploratory laparotomy, there are 2 components. In an exploratory laparotomy, there are 2 components that are going to be present. Right. So, the first one, if it is a viable bowel. If there is a viable bowel, this is what we call it as the diversion colostomy. This is what we call it as the diversion colostomy. This is your diversion colostomy. If it is a non-viable bowel, then you will do a Hartmann surgery. Non-bowel basically means gangrene, right? So here you will perform a Hartmann's surgery. Hartmann surgery is a temporary colostomy. Hartmann's surgery is going to be a temporary colostomy. Hartmann surgery is going to be your temporary colostomy. Clear? Okay. Chalo. Now, another very important topic that you'll see from your bowels is going to be your inflammatory bowel disease. Now, in the inflammatory bowel disease, you have Crohn's disease as well as ulcerative colitis. Now, Crohn's, the age, see both of them are IBDs only, that's inflammatory bowel disease. The age of presentation is going to be same. So, earlier in a young age, it is 20 to 30 years and the second presentation is after the age of 50 years. So, they are bimodal presentation. So, the earlier presentation will be at 20 to 30 years and the second peak that you will see is at the age of 50 years. Now, alright guys. Just hold on for a second. Okay. So now when you talk about the sex, in Crohn's disease, it is more common in females when compared to males. Ulcerative colitis is also slightly more common in females when compared to males. When we talk about risk factor for Crohn's, it is usually smoking. It is secondary to tuberculosis as well as dietary risk factors. Ulcerative colitis is purely an autoimmune disorder, so hence it does not have any specific risk factors. Nothing is protective in Crohn's, but it has been found that the smoking is protective in ulcerative colitis. Smoking is protective in ulcerative colitis. Now the genes which are responsible here is going to be NOD2 and CARD15. It is a NOD2 and CARD15. There is no specific gene in your ulcerative colitis. Now see, Crohn's disease is going to involve from the oral cavity to anal canal. The most common site is going to be terminal ileum in Crohn's, and the most common site in ulcerative colitis is going to be rectum. It is going to be rectum. One magic word to remember between these two. Crohn's will usually present to you with obstructive symptoms. Ulcerative colitis will present to you with diarrhea. Radiological features that you can see, the first one, these strictures that you can see is what we call a string sign of Cantor. The string sign of Cantor is seen in Crohn's disease, and the lead pipe appearance. The lead pipe appearance. The lead pipe appearance is what you see in ulcerative colitis. This is what you see in ulcerative colitis. Now, on a gross specimen for Crohn's disease, this is your cobblestone mucosa. It's a cobblestone mucosa, and this is going to be the bear claw sign. This is going to be the bear claw sign. So you have the cobblestone mucosa and you have the bear claw sign. Other things that you'll see, this is going to be mesenteric fat creeping. There'll be mesenteric fat creeping and the transmural stricture. And there's a transmural stricture. This is a transmural stricture. This is a transmural stricture. Ulcerative colitis, on the other hand, they have pseudopolyps. They have pseudopolyps and continuous lesion. And the continuous lesion. Now, when I say in Crohn's disease, what extra GI manifestation that you have to remember? For Crohn's, remember the erythema nodosum. And for ulcerative colitis, remember arthritis. Management here is going to be medical. For ulcerative, it is medical. If medical fails, then it has to be surgery. And the surgery that you're going to do is going to be total proctal colectomy. Total proctal colectomy with ileoanal. With ileoanal J pouch anastomosis. With ileoanal J pouch anastomosis. So total proctal colectomy with ileoanal J pouch anastomosis. It's a total proctal colectomy with ileoanal J pouch anastomosis, right? So this is what we are going to do in terms of both Crohn's as well as ulcerative colitis, right? Hereditary cancer syndrome is again a very important topic. So quickly recapping between the familial adenomatous polyposis, Gardner syndrome, Turcotte syndrome, as well as your Peutz-Jeghers syndrome. See, all these conditions, all familial cancer syndromes are going to be autosomal dominant in disorder. So all of them, let it be FAP, Gardner syndrome, Turcotte syndrome, or the Peutz-Jeghers syndrome, all of them are autosomal dominant disorders. All of them are going to be autosomal dominant disorders. Now, the first three are basically FAP spectrum diseases only. So hence you will notice that all of them will have an APC gene mutation. So familial FAP is APC, Gardner is also FAP, Turcotte is also APC gene mutation. Peutz-Jeghers syndrome is going to be STK11 gene mutation. Now, the chromosome which is involved, the chromosome for FAP is going to be 5q, Gardner is 5q, Turcotte is 5q, but when you talk about Peutz-Jeghers syndrome, it is chromosome number 19p, right? It is misprinted here. It is chromosome number 19p. It is a chromosome number 19p. Now, for the features of familial adenomatous polyposis, there are multiple polyps. There are more than 100 polyps here. There are more than 100 polyps. For Gardner's, remember the mnemonic as for fed. We have already discussed it before. F stands for FAP, O stands for osteoma, R stands for retinal pigmented epithelium, another F stands for FAP, that is fibroma, E stands for epidermal cyst, and D is your desmoid tumor, right? Turcotte syndrome is basically familial adenomatous polyposis with brain tumors. And these are gliomas and multiblastoma. GBM, that is your glioblastoma multiforme. Okay. Now, Peutz-Jeghers syndrome, remember PJNH, that is polyps with pigments. It is polyps with pigments. The most common type of polyp that you will see in Peutz-Jeghers syndrome, that is your H, that is your hamartomas polyp. That is your hamartomas polyp. And the most common site is going to be jejunum. The most common site is going to be jejunum. So this is your hereditary cancer syndromes and their important data. Now, we have the list of GI disorders and we look at the most common type or the most common site. Just give me a second. Right. In the tracheoesophageal fistula, the most common type is going to be the type C variety. It is a type C variety. Achalasia cardia, it is the lower 1/3 of the esophagus. Lower 1/3 of the esophagus is the most common site. Zenker's diverticulum is going to be in the cervical esophagus. And that too on the posterior surface. Esophageal cancer, the most common site is middle 1/3 of the esophagus. Barrett's is the lower 1/3 of the esophagus. The web in the Plummer-Vinson syndrome is in the upper esophagus. We call it as the upper esophagus. The upper 1/3 of the esophagus. Boraf syndrome, the perforation occurs in the lower 1/3 of the esophagus. Mallory-Weiss tear occurs in the cardia of stomach. It is the cardia of stomach. Peptic ulcer disease, the most common site is the first part of the duodenum. For gastric ulcers, it is the antrum of the stomach and that too on the lesser curvature. that on the lesser curvature. Intersusception, if I say what is the most common site in children, intersusception in children, it is ileocolic. In adult, it is colocolic. In adults, it is going to be colocolic. If I say volvulus, remember the most common site for volvulus is the sigmoid colon. The most common site for diverticulosis is also sigmoid colon. The most common site for polyps overall is going to be rectum. For TB stricture, which is also called as the belt-shaped stricture, also called as the belt-shaped strictures, they are seen in the terminal ileum. They are seen in terminal ileum. For typhoid perforation, this is also most commonly seen in terminal ileum. For ulcerative colitis, rectum is the most common site. Crohn's disease, terminal ileum is the most common site. For Hirschsprung disease, rectum is the most common site. Rectum is the most common type, right? So these are the disorders and the most common site. For ischemic colitis, the most common site is going to be splenic flexure. For superior mesenteric artery syndrome, remember it is the middle colic artery which is more commonly blocked. For acute mesenteric ischemia, now when we talk about acute mesenteric ischemia, it is going to present to you with thumbprint site, but again it is more common on the splenic flexure. For large intestinal malignancy, it is your rectosigmoid. It is your rectosigmoid. If this is not in the option, then rectum. If it is not in the option, then it is going to be the sigmoid colon. Then it is going to be the sigmoid colon. Perforation in the peptic ulcer disease is more commonly seen in duodenal ulcers and hemorrhage in your gastric ulcers. The most common source of bleeding in peptic ulcer disease is your gastroduodenal artery. It is the gastroduodenal artery. Fistula in ano, if they ask you what is the most common type, according to the Parkes classification. According to the Parkes classification, the most common is going to be the intersphincteric type. It is the intersphincteric type. Hemorrhoids, it is the internal hemorrhoids which are more common when compared to external. Internal more common when compared to external, and 3, 7 and 11 o'clock is more common as the primary sites. For anal cancer, it is below the dentate line. It is below the dentate line. And below the dentate line, you will have squamous cell carcinoma. It is the squamous cell carcinoma, right? So these are all the important disorders, their most common locations, which are going to be asked in the exam. The second list is the named ulcers and where do you find them. Aphthous ulcers is going to be Crohn's disease. The aphthous ulcer is going to be the Crohn's disease. Cameroon's ulcer is going to be in hiatal hernia. It is in hiatal. Peptic ulcer disease. It is, see, hiatal hernia, I would say the aphthous ulcer is seen in Crohn's disease. The most common site is terminal ileum. Hiatal hernia, which is usually seen it is a fundus of the stomach. It is a fundus of the stomach, which will have the Cameroon's ulcer, which is also called as the Riding's ulcer. Peptic ulcer disease, the most common site is the first part of the duodenum. The gastric ulcers is the antrum is the most common site. And that too on the lesser curvature. Duodenal ulcer is the first part of the duodenum. Tubercular ulcers is the terminal ileum. Typhoid ulcer is also going to be on the terminal ileum. Belt-shaped ulcers are nothing but TB ulcer. So TB ulcers are again more common in the terminal ileum. They're more common in the terminal ileum, right? So these are the named ulcers and their most common sites. The other named ulcers are flash-shaped ulcers, which are seen in Entamoeba histolytica. Now this Entamoeba histolytica induced ulcer, which is a flash-shaped ulcer, is seen in cecum. Cecum is the most common site when compared to ascending colon, right? Serpent ulcers, which is seen in necrotizing enterocolitis. So these serpent ulcers are seen in necrotizing. It is seen in necrotizing enterocolitis. Cobblestone mucosa is seen in Crohn's disease, which is seen in terminal ileum. Solitary rectal ulcer is usually seen in rectal prolapse. And the most common site is going to be the ampulla of rectum. It is the ampulla of rectum. Skip ulcers are seen in Crohn's disease, and the most common site for the Crohn's disease is going to be your terminal ileum. It is going to be your terminal ileum. So these are the named ulcers and their locations. Now, what are the GI malignancies and the preferred chemo? Let's do a quick recap. For esophageal cancers, we prefer ECF, that is epirubicin, cisplatin, and 5-fluorouracil. For carcinoma stomach, it is also ECF. So for small intestinal adenocarcinoma, we give Folfox. In Folfox, FOL stands for folinic acid. Another F stands for 5-fluorouracil, and OX stands for oxaliplatin. OX stands for oxaliplatin. For large intestinal adenocarcinoma also, either you can give Folfox or another one is Folfoviri. Right. So here everything is same. The IRI stands for irinotecan. It is a irinotecan. Now this is one of your favorite exam questions. It is a GI malignancy. They are proximal margin for resection and the distal margin for resection. Now for esophageal cancer, the proximal margin for resection is 10 centimeters. The distal margin for resection is 5 centimeters. Rest everywhere, the proximal and the distal margin. The proximal and the distal margin will almost remain the same at 5 centimeters. The exception that you will see is going to be at rectum. The distal rectal margin is 2 centimeters. So the entire exception to the rule is the proximal margin in the esophagus and the distal margin in the rectum. Rest everywhere it is consistent with 5 centimeters. Rest everywhere it is consistent with 5 centimeters. It is consistent with 5 centimeters. See? It is consistent with the 5 centimeter mark. Okay. So 10 centimeters is the proximal margin in the esophagus and 2 centimeters in rectum. Rest everywhere it is 5 centimeters. Okay. The continuation in terms of your chemo regimes. For anal carcinoma, we follow the Negros regime, and this is for squamous cell cancer. It is for squamous cell cancer of the anal canal. It is squamous cell cancer of anal canal. It is a squamous cell cancer of the anal canal. It is a squamous cell cancer of the anal canal. Right. Now, what do we give? We give something called as the Negros regime. So, Negros regime is actually your chemo radiation. The Negros regime is what we call it as the chemo radiation. So, in a chemo radiation, number one, we give 5-fluorouracil. With mitomycin C and radiotherapy. 5-fluorouracil with mitomycin C and radiotherapy. It is for anal cancer. For gastrointestinal stromal tumor, we give imatinib. If there is resistant to imatinib, for imatinib resistant GIST, we give sunitinib. So sunitinib is the drug of choice. It is a drug of choice for imatinib resistant. For the imatinib resistant GIST. It is a drug of choice for the imatinib resistant GIST. For HCC, we would like to give sorafenib. Now, sorafenib is given for stage C. according to BCLC criteria, it is your stage C, right? Here you have what is stage C. If you remember, the child per classification can be A or B. PST can be 1 or 2. There is positive lymph node and metastasis. In these conditions, you can give sorafenib. This was a previous exam question also. They asked you what is the indication for sorafenib. For gallbladder cancer and hepatobiliary malignancies, they are almost the same. That is going to be your gemcitabine based chemotherapy. So your hepatobiliary and pancreatic malignancies, we give gemcitabine based chemotherapy. Remember, pancreatic malignancies are chemo resistant because of the anoxic state. Gemcitabine is given as a palliative care, but gallbladder carcinoma and cholangiocarcinoma, we give gemcitabine with cisplatin. Now, the disorders and the surgical management. We're talking about purely what is the surgical management that you have. For achalasia cardia, the surgery of choice is going to be your Heller cardiomyotomy. But in the exam, if they ask you which is a better one, then the answer is going to be Heller-Dor surgery. If you have attended my lecture, you would have noticed that Heller's cardiomyotomy causes GERD. To prevent GERD, you do a Dor surgery, which is a partial anterior fundoplication. So if you combine those two, that becomes the surgery of choice. That is your Heller-Dor surgery. For diffuse esophageal spasm, it is medical management. Yes, one option that they can give you is your long esophageal myotomy. Now, this long esophageal myotomy, the long esophageal myotomy is going to be associated with a very poor outcome. So, hence it's a last resort. For Zenker's diverticulum, if it is less than 3 centimeters, then you have diverticulectomy. And if it is more than 3 centimeters, then you have the Dolman surgery. Then you have the Dolman surgery, which is the endoscopic Dolman surgery. This is the endoscopic. This is the endoscopic Dolman surgery. For esophageal cancer, we have 3 surgeries, if you remember. Number 1 is your Ivor-Lewis. Number 2 is your McEwen's. And number 3 is your Oringer's. And currently the surgery of choice is going to be Oringer's. Currently the surgery of choice. Currently the surgery of choice is going to be Oringer's. It is going to be Oringer's is the surgery of choice. For congenital hypertrophic pyloric stenosis, it's your Ramsted's pyloromyotomy. It is the Ramsted's pyloromyotomy. For perforation peptic ulcer disease, you do Graham's omental patching. It is a Graham's omental patching. It is a Graham's omental patching. For peptic ulcer disease, it is the triple or the quadruple therapy. See, GRD, the first line management is always going to be medical. If the medical management fails, then the surgery of choice is going to be Nissen's 360 degrees posterior fundoplication. It is a Nissen's 360 degrees posterior fundoplication. For a D1 stricture, you can do a stricturoplasty. You have Heineken-Mucklitz. And Jablois. There are 2 surgeries that you have. For duodenal atresia, we do duodenostomy. For jejunal atresia, we do jejunostomy. For ulcerative colitis, after failure of medical management, after the failure of medical management, you can go ahead with total proctal colectomy with ileoanal J pouch. With ileoanal J pouch anastomosis. For diverticulosis, it is your elective sigmoid resection. For FAP, it is same as ulcerative colitis, that is your total proctal colectomy with ileoanal J pouch. With ileoanal J pouch. For rectal prolapse, see in rectal prolapse, you should know which of the following is an abdominal approach, which is the following is a perineal approach. Now, when I say the perineal approach in rectal prolapse, in the perineal approach, remember the 𝐒𝐻 wiring. And for abdominal approach, remember Repstein and Freichmann-Goldberg. This is your Repstein's and the Freichmann-Goldberg. For Hirschsprung disease, you have to do pull-through surgeries. The list of the pull-through surgeries is Duhamel. It is your Duhamel, Swenson, and Sowas. So Duhamel, Swenson's, and Sowas are the 3 surgical options that you can do for Hirschsprung disease. See, Altemeier's, okay, so when you talk about the rest of them, see, I don't want to overburden you with a lot of information. These are the surgical names that were given in the INI, right? If I go and talk about it, then in the perineal route that you have the 𝐒𝐻 wiring is there, Altemeier's is there, Delrom's is there, right? So there is Altemeier, there is Delrom. All these are perineal approaches. But again, let's not overburden ourselves with a lot of information. Let's try to keep it to the one that we actually can understand and stick to it. Okay? So the perineal approach is 𝐒𝐻, Altemeier, and Delrom surgery. It is a 𝐒𝐻, Altemeier, and Delrom. Sure. Okay. For hemorrhoids, in an open hemorrhoidectomy, you have 2 surgeries. Number 1 is Milligan-Morgan. Is preferred over Ferguson's. For adenocarcinoma of the anal canal, then you have to do an APR. That is an abdomino. It's an abdominoperineal resection. It's the abdominoperineal resection. It is an abdominoperineal resection. See? So these are all the entire GIET list, the topics. So whatever I've discussed, no, all these are previous exam questions, but the topics are equally important. Just go through them once. So far, any doubts? Quick feedback. So far, any doubts? Quick feedback. Okay. If there's no problem, let's move on to the liver resection terminology. Now, this terminology is given by Brisbane. We call it as the Brisbane's terminology of liver resection, right? Now, if you're talking about the right hemiliver or the right hepatectomy, you will remove 5, 6, 7, and 8. Left hepatectomy is 2, 3, 4A, and 4B. Right anterior is going to be 5 and 8. Right posterior is going to be 6 and 7. Left lateral is going to be 2, 3. And left medial is going to be 4A and 4B. When you do 3 segments from the right side, that is going to be 5, 6, 7 and 8 plus 4A, 4B. Left trisectionectomy will be 2, 3, 4A, 4B with segment 5 and 8. With segment 5 and 8. This is a left trisectionectomy. Brisbane's terminology has been your previous exam question. Okay? Now, another question that they usually ask you is about the liver infections. Now, in the liver infection, we have 3 topics that we'll discuss: pyogenic liver abscess, amoebic liver abscess, and hydatid cyst. Out of these 3, there are 2 abscesses, that is a pyogenic and amoebic liver abscess. Out of these 2, which is not a true abscess, and that's also an exam question. Remember, amoebic liver abscess is not a true abscess. It is not a true abscess. So what is this? It is an example of liquefactive necrosis. This is an example of a liquefactive necrosis. This is an example of a liquefactive necrosis. All right. Now, the causative agent, when you talk about each individual, for pyogenic liver abscess, it is E. coli and Klebsiella. For amoebic liver abscess, it is Entamoeba histolytica. And for hydatid cyst, it is Echinococcus granulosus. How do they spread to the liver? The most common route of spread for pyogenic is via the bile duct. The other 2, the parasites usually spread via the portal circulation. They usually spread via the portal circulation. Of all these, remember, pyogenic liver abscess is seen in elderly patients. The rest, both of them are seen in relatively younger age group. Right? Now, for both abscesses, when I say pyogenic liver abscess and the amoebic liver abscess, they're more common in males. But when you talk about the hydatid cyst, it is equally seen in males as well as females. We don't know why, but all infectious disorder of the liver is more common on the right side. All of them are more common on the right side when compared to left. Bacteria, whenever they proliferate, they will have multiple puddles. The other 2 is going to be solitary. The other 2, it is going to be solitary lesions. The other 2, it is going to be the solitary lesions. Bacteria can never be endemic. The parasites usually have the endemic status. Both amoebic and pyogenic liver abscess will have hepatitis. That is, inflammation of the liver will be present. So they'll have features similar to that, right? So hence there'll be right hypochondriac pain, fever. So the only thing that differentiates pyogenic liver abscess from amoebic liver abscess, in pyogenic liver abscess, there will be history of jaundice. There will be history of jaundice. And in amoebic liver abscess, there will be history of colitis. There is history of colitis. On the other hand, hydatid cyst is usually asymptomatic. The hydatid cyst is usually asymptomatic. Now, the first investigation for all hepatobiliary disorders is going to be ultrasound. Now, if they ask you what is the classification which is done on the basis of ultrasound for the hydatid cyst, the answer is going to be the Gerbe's classification. In order to confirm, if I say what is the investigation, in order to confirm, you should always culture. For bacteria, parasites cannot be cultured, so hence it will be ELISA. For the diagnostic purposes, what is the investigation of choice? For all hepatic lesions, the investigation of choice is going to be contrast CT. That is your triple phase CT of the liver. Now, for pyogenic liver abscess, you aspirate, give antibiotics. For amoebic liver abscess, high dose metronidazole. If they say how much is high dose, remember the high dose metronidazole is going to be 750 to, or I can say 700 to 1000 milligrams. It is 700 to 1000 milligrams 3 times a day. That is TID for 10 to 15 days. Now, in terms of your hydatid cyst, you do pair therapy. Small correction here. It is going to be the pair therapy. This is going to be the pair therapy. Now, in the pair therapy, it is puncture aspiration of the hydrated fluid. It is puncture aspiration. It is a puncture aspiration of hydrated fluid and installation of scolicidal agent and re-aspiration. So it is puncture aspiration of the hydrated fluid and installation of scolicidal agent and re-aspiration. What are the scolicidal agents? Is hypertonic saline, 10% povidone, 0.5% centrimide. It is 0.5% centrimide. It is 0.5% centrimide and 0.05% chlorhexidine. The 0.05% chlorhexidine. But anaphylaxis is a risk that you will have in any time you are doing an aspiration hydrated fluid. So you always have your adrenaline and hydrocort ready with you, right? The risk for anaphylaxis is more when you do a test called as Cassini's test. है ना? अभी तो वो obsolete हो गया. Now we stick to ELISA. Cassini's में क्या था? Hydrated fluid aspirate used to be taken, injected in subdermal space, like same you do in TB, no? Montu test की तरह. Same was to be done, but now it is not performed. The reason why Cassini's is not performed because of poor sensitivity. है ना? The overall sensitivity of the Cassini's was only 60 to 70%. ELISA has a sensitivity of 90 to 95%. So hence it is now conveniently used as ELISA as the investigation of choice. All right. So this is in terms of infectious disorders. Now this was the last session's question, the comparison between the primary HCC. The comparison between the primary HCC and the fibrolamellar variant of HCC. Now in a primary HCC, males were more commonly affected when compared to females. The ratio is as high as 8:1. Fibrolamellar variant, males and females are equally affected. The average age for HCC. The average age for HCC is 55 years and fibrolamellar variant is around 25 years. The tumor nature, it is going to be aggressive and they are poorly demarcated. They are poorly demarcated. Fibrolamellar variant is a well demarcated. That is a well demarcated. Only 25% of HCCs are resectable, whereas 75% of fibrolamellar variants are resectable. It is associated with liver cirrhosis. Fibrolamellar variant is not associated with liver cirrhosis. The AFP level is elevated here. The AFP level remains normal in fibrolamellar variant. It is associated with hepatitis B. There is no association with hepatitis B in fibrolamellar variant. The prognosis is poor in your HCC and the prognosis in your fibrolamellar variant is relatively good, right? Now, if the AFP, that is alpha fetoprotein levels, are normal, what are the tumor markers that you see in fibrolamellar variant? The tumor markers are number one, neurotensin. Another one is your B12 binding protein. It is your B12 binding protein. Now, when I say the other tumor marker that you have is going to be PIVACA2. PIVACA2 is your protein induced vitamin K absence. It is protein induced vitamin K absence 2. PIVACA2 is a protein induced vitamin K absence 2. Okay. So this is the comparison between the primary HCC and the fibrolamellar variant. Now, when we talk about the cystic lesion of pancreas, you have the pseudocyst, the serous cyst, the mucinous, and the IPMN. The most common cystic lesion. The most common cystic lesion of pancreas is pseudocyst, but the most common cystic neoplasm. Because pseudocyst is not a neoplasia, it's a cystic lesion. It's a pseudocyst. Fluid-filled cavity not lined by epithelium is what you have is pseudocyst. Mucinous adenoma is a true neoplasm that you are going to see. Now, every single time you address right? The cystic lesion of the pancreas, all of them will present above the age of 50 years, except for pseudocyst, which is seen between 40 to 50 years. Serous cyst is 60 to 70 years. Mucinous is going to be 50 to 60 years. IPMN is between 60 to 70 years. It's going to 60 to 70 years, right? Pseudocyst of the pancreas is equally seen in males and females. IPMN is also equally seen in males and females. The serous cyst and the mucinous cyst is more commonly seen in males when compared to females. They're more commonly seen in males when compared to females. See? Now, the appearance is very important in terms of the cystic lesion of pancreas. One second. Right? The appearance is more common. Okay. Sorry, small correction here. These two are more common in females, not males. Sorry. So these two disorders are more common in females when compared to males. All right. Now, when you talk about appearance, number one, you see pseudocyst is going to be a very big cyst. So it is usually more than 6 centimeters, right? It is more than 6 centimeters in diameter. It is thick walled. It is more than 6 millimeter in thickness, and it is going to present beyond 12 weeks of pancreatitis. Serous adenoma, they were honeycomb appearance. Just remember honeycomb. For mucinous, remember peripheral eggshell calcification. There is presence of eggshell calcification. There is eggshell calcification. Whereas in IPMN, remember there is presence of fish mouth ampulla. There is presence of fish mouth ampulla. Now, in the pseudocyst of the pancreas, if it is associated with acute pancreatitis, there is no communication. But if it is secondary to a chronic pancreatitis, they usually have a ductal communication. The serous cyst and the mucinous cyst do not have any ductal communication. IPMN develops within the duct, so obviously it will have the ductal communication. The most common site for the pseudocyst of the pancreas is going to be the lesser sac. Serous adenoma is equally distributed throughout the pancreas. It is equally distributed throughout the pancreas. Mucinous cyst is going to be body and the tail of the pancreas. IPMN is more common on the head of the pancreas. Now, when you talk about in the exam, they will ask you these 3 tables. Now, this is what you have to remember in the cystic lesion. Now, pseudocyst and serous cyst will not have mucin stain. The other two, the name itself have mucin in their name. Mucinous adenoma and intraductal papillary mucinous neoplasm, they will be positive for mucin stain. CA levels will be normal in these two, and mucin secretion is a pre-malignant status, so CA is elevated. Amylase is going to be elevated in pseudocyst, they remain normal in these two and elevated in IPMN. When we talk about investigation, it is going to be CECT with pancreatic protocol for all 3 of them. But for IPMN, it is your MRCP. It is your MRCP. Management, if it is going to be beyond 12 weeks, then it is surgery. So beyond 12 weeks, if the pseudocyst persists, then you take the surgery, and the surgery here is either you can do a cystogastrostomy, or a cystogegnostomy. For serous adenoma, it is enucleation. For mucinous adenoma, it is distal pancreatectomy. It is a distal pancreatectomy. If it is on the head of the pancreas, no, for IPMN, then it is Whipple's. Then we prefer doing Whipple's. The maximum malignant potential among all the cystic lesion of pancreas is associated. The maximum it is associated is with IPMN. See, here you can do both cystogastrostomy and cystogegnostomy, but remember, cystogegnostomy is the surgery of choice for pseudocyst of the pancreas. It is the surgery of choice. It is the surgery of choice for the pseudocyst of the pancreas. It is the surgery of choice for the pseudocyst of the pancreas. For the pseudocyst of the pancreas. Okay? Now, so this is the cystic lesion of pancreas that are going to be important from the exam perspective. Now, what are the important triads that they can ask you in the exam? The first one is your Carney's triad. So, Carney's triad, you have multifocal gist, not just gist, remember multifocal gist. So Carney's triad will have multifocal gist with extra-adrenal paraganglionoma. These paragangliomas are extra-adrenal. The extra-adrenal paraganglionoma and pulmonary chondroma is called as the Carney's triad. Macular triad is seen in Boerhaave syndrome. In Boerhaave syndrome, the patient is going to have retching or vomiting, followed by retrosternal chest pain and surgical subcutaneous emphysema. Third is your Bouchard's triad. The Bouchard's triad is seen in gastric volvulus, right? So pain, retching without vomiting and inability to pass nasogastric tube is what we call as Bouchard's triad. Then you have Murphy's triad, which is seen in appendicitis. So in appendicitis, patient is going to have pain, fever and vomiting. And the last one that you have is your Charcot's triad, which is seen in cholangitis. All of them will be intermittent. That is intermittent pain, intermittent fever and intermittent jaundice. And this usually occurs secondary to CBD stones. Then you have the Quincke's triad, also called as the Sandbellum's triad, which is seen in hemobilia, that is blood in bile. Hemobilia is blood in bile. If there is bile in blood, it is called as bilhaemia, which is more dangerous. This is hemobilia. So in hemobilia, there will be pain, there is jaundice and associated with melena. The last one, which is repeatedly asked in the exam, is for mesenteric cyst, called as the Tilloch's triad. So the Tilloch's triad is seen in mesenteric cyst. So what is the Tilloch's triad? The Tilloch's triad is associated with the mid-abdominal cystic swelling, which moves only perpendicular to the attachment of the mesentery, and then there's a bowel, there's a band of resonance around the cystic lesion. So it is only mobile perpendicular. It is only mobile perpendicular to the root of the mesentery, which is called as a Tilloch sign, right? And a band of bowel resonance in front of the cyst. Now, very, very important. Do differentiate between Tilloch's triad and Tilloch sign. Tilloch's triad is combination of all these three, but Tilloch sign is where you're demonstrating that the cystic lesion will move perpendicular to the root of mesentery, but never along the line of mesentery. Never along the line of mesentery. Okay? So this is all the important triads. Now this has been asked multiple times, right? So all 7 triads is your previous exam question. I just want you to go through them once, and at least one question you can anticipate from this particular table. Okay? So now again a spotter in GIT, which I can ask you. The first one you can see ultrasound. This, what you can see is what we call it as the antral nipple sign. This is what we call as the antral nipple, the cervix sign, also called as the cervix sign. Now remember, the criteria is if the length is more than or equal to 6 millimeters and width is more than or equal to 4 millimeters, then it sits into the diagnosis of your IHPS or CHPS. IHPS stands for the idiopathic hypertrophic pyloric stenosis, and CHPS is congenital hypertrophic pyloric stenosis. Again, one thing, the electrolyte imbalance. The electrolyte imbalance. The electrolyte imbalance that you're going to see here. What is the electrolyte imbalance that you have? Number one, this is metabolic alkalosis with hypochloremia, hypokalemia, and paradoxical aciduria. And paradoxical aciduria. And the paradoxical aciduria. If you do a contrast imaging in CHPS, if you perform a contrast imaging in CHPS, you will see 2 important signs. The 2 important signs that you will see is double track sign and the mushroom sign. You can see here, this is like a mushroom and a double track. 2 tracks and a mushroom sign. A double track and a mushroom sign. Now, if you see here, this is again a spotter that you cannot miss. That is free gas under right hemidiaphragm. And the free gas under right hemidiaphragm is seen in hollow viscous perforation. It is seen in hollow viscous perforation, and that hollow viscous perforation is your free gas under right hemidiaphragm. Free gas under right hemidiaphragm. Free gas under right hemidiaphragm. Now, conditions where you will see this. Number one is perforation in peptic ulcer disease, typhoid ulcer perforation, and acute, that is your appendicular perforation, and also in appendicular perforation. If you have delayed presentation in a hollow viscous perforation, for a delayed presentation of hollow viscous perforation, the whole abdomen will be filled up with air. Now, because the whole abdomen is going to be filled up with air, it appears like football, and you can see the bowel wall starts to get visualized. Why? There is air inside the bowel, air outside the bowel, and the bowel wall gets delineated, and that delineation of the bowel wall is what we call it as a regular sign positive, right? So what are the signs that you have? You have the football sign, the dome sign, also called as the distension sign, and this is your regular sign. Regular sign is nothing but visualization of the bowel wall. Another one that you see is a cupola sign, right? So there are the signs that you will see in a hollow viscous perforation with delayed presentation. Now, if you see this CT image, there is a stone, there is a colonic loading, and the air in the biliary system. Obstruction is there, stone is there, and then air in the biliary system, that is pneumobilia, and this is what we call as the macular striate. This is what we call it as, sorry, it's a regular striate. So what do you have? You have stone, B is your obstruction, C is your pneumobilia. The most common site for development of the fistula is a cholecystoduodenal fistula. It's a cholecystoduodenal fistula. Okay. So what is a regular striate? So macular striate is seen in, which accidentally we said it, maculus is seen in Boerhaave syndrome. This is a regular striate. So in the regular striate, what do you have? You have gallstone ileus. Okay. You have gallstone ileus is seen in for a regular striate. So what is it? Gallstone ileus or the regular striate? Stone, obstruction, and pneumobilia, right? So most common cause is a bilioenteric fistula. Now we have already discussed this in the previous radiographs also. The double bubble sign will be seen in two conditions, that is your duodenal atresia as well as annular pancreas. Multiple air fluid levels, when we say it is multiple, if there are more than 3 in a step ladder pattern, then I know that you're dealing with your small bowel obstruction. You're dealing with a small bowel obstruction. You're dealing with a small bowel obstruction. Now, if you have a hair-filled stomach, this is also called as the trichobezoar or also called as the Rapunzel syndrome. And this occurs secondary to a psychiatric disorder. It's called as trichotillomania. Patient plucks the hair and eats it. Now, you see, this is again a repeat radiograph that you'll see. This is called as the thumbprint sign. Now, the thumbprint sign is seen in ischemic colitis, and the most common site for the ischemic colitis is your splenic flexure. Then you have accordion sign. The accordion sign, as you can see, there is alternate black and white, that is accordion. And the accordion sign is seen in pseudomembranous colitis. The accordion sign is seen as in pseudomembranous colitis. Now, in the congenital diaphragmatic hernia, CDH, the most common congenital diaphragmatic hernia is going to be the Bosch-Talek hernia. It is the Bosch-Talek hernia. In the Bosch-Talek hernia, you can see there is there are bowel loops in the left hemithorax, right? In the Bosch-Talek hernia, if they ask you where is the defect is going to be left-sided posterolateral. It is the left-sided posterolateral defect. It is the left-sided posterolateral defect. It is a left-sided posterolateral defect. Okay. Pseudomembranous colitis usually have thickening of the bowel wall, not edematous. Okay. It's a secondary context of it. Okay. Apple core sign we have already discussed for esophageal cancer. But how do you know that this apple core is not, or let's keep it this way. This apple core sign is seen in which condition? Quick feedback. This apple core sign, I'm saying it is not esophagus. So what is it? You can clearly see that there are these hostrations. So whenever you have hostration, there is going to be colon. So when you have colonic hostrations with apple core sign, this is only possible in colon cancer. This is going to be in colon cancer. It's going to be seen in colon cancer. It is a colon cancer. ठीक है? चलो. Claw sign is seen in interception. We have already dealt with that, right? claw sign is seen in interception. You can see here, this is the trapping. Now, technetium 99, presence of ectopic foci. Technetium 99. One second. So, technetium 99, when you do, if there's presence of an ectopic foci, the presence of an ectopic foci is seen in Meckel's diverticulum. So, diagnosis will become the Meckel's diverticulum. The diagnosis will become Meckel's diverticulum, right? So, the Meckel's diverticulum follows the rule of 2. That is seen in 2% population. That is, this is the most common congenital disorder. The most common congenital disorder of intestine. The most common congenital disorder of the intestine, right? It is 2 inches in size and 2 feet proximal to IC junction. That is your 𝐒𝐿-CECL junction. When I say IC junction, it is 2 feet proximal. It is 2 feet proximal to 𝐒𝐿-CECL, IC junction. So at 2 feet, it is approximately 60 centimeters, right? Right. Another rule of 2 that you will see, they have got 2 different mucosas. When you talk about 2 different mucosas, one is your ectopic gastric mucosa. One, you have the ectopic gastric mucosa. Another one is your pancreatic mucosa. Now, Meckel's diverticulum is an example of a true diverticulum. It's a congenital diverticulum, right? The most common tumor that you see in Meckel's diverticulum, this is also a previous exam question. It is your neuroendocrine tumor. It is your neuroendocrine tumor. Now, when you have the coffee bean sign on an X-ray, this is what we call it as volvulus. The bird of prey sign you will see again in volvulus. When you see the sawtooth sign is seen in diverticulosis. So this is, you can see, this is a sawtooth sign. So sawtooth sign is seen in diverticulosis. It is seen in diverticulosis. In diverticulitis, it is the inflammation of diverticulosis. It is the inflammation of diverticulosis. This is the inflammation of the diverticulosis. Remember, the classification that we use for the inflammation of diverticulosis is what we call it as the Hinchey's classification. And remember, Hinchey's classification is done on the basis of CECT, right? Haggett is another classification that is done for polyps. So Hinchey's is for diverticulitis. Hinchey's is for diverticulitis, and the Haggett's classification is for polyp. The Haggett's classification is P for polyp. Okay. Clear? Chalo. Now, in urology, couple of important topics that has to be discussed. Number one is a nephrolithiasis. Remember, 90% of your renal stones are radio-opaque. If you extrapolate this data, you will find that 80% of the stones are radio-opaque in silolithiasis, and 10% of them are radio-opaque. 10% of them are radio-opaque in gallstones. 10% of them are radio opaque. 10% of them are in radio opaque status. Okay. That's your gallstones. So that's the data that you need to remember about the radio opacity. Now, in the calcium oxalate, it is because of excessive amount of calcium excretion. Hypercalcemia, hypercalciuria, hyperoxaluria. Phosphate is because of protease infection. Uric acid is because of increased DNA destruction, example like gout. Cysteine is because of cystinuria. When you say characteristic feature of calcium oxalate stones, remember the calcium oxalate stones are the most common stones overall. They are round to oval in shape and they have sharp projections. They have sharp projections. Phosphate is what we call it as the triple stone. They're called as the triple stone. The phosphate stones is what we call it as the triple stone. Right? Along with it is also called as the struvite stone, staghorn calculi, triple stone, struvite stone, and the staghorn calculi. Uric acid stones, they are formed in acidic urine. They're formed in acidic urine. Now, because they're formed in acidic urine, the management here will be alkalization of urine, as simple as that. Cysteine stones, they are hard and they're dirty black. And they contain sulfur. They contain sulfur. Calcium oxalate is radio opaque. Phosphate is radio opaque. Uric acid is radiolucent. Cysteine is also radio opaque because of sulfur. When we talk about the crystals, the calcium oxalate stones have the envelope shaped crystals. So they look like this. They are envelope shaped crystals. They have the envelope shaped crystals. Phosphate stones have the phosphate stones have the coffin-lid crystals. Uric acid stones will be multi-faced. Cysteine stones will have hexagon. It's the hexagon. Cysteine stones are going to be hexagon. So these are the characteristics of your nephrolithiasis. These are the characteristics of your nephrolithiasis. Now, when we talk about the investigation in nephrolithiasis, when you have the investigation in nephrolithiasis, the first investigation that you would do as an ultrasound to look at the size, location, and the status of hydronephrosis. X-ray QUB is the first investigation if the patient presents with ureteric colic. CT urography, which is the non-contrast CT of the kidney, is the investigation of choice for nephrolithiasis. The DMSA scan, which is a radionucleotide scan, which is basically dimercaptosuccinic acid, is done to evaluate for the morphology, scarring, and anatomy. Easy to remember, DMSA, morphology, scarring, and anatomy. Then you have DTPA scan, so diethyl triamine pentaacetic acid, which is the investigation of choice. It is diethyl triamine pentaacetic acid. Diethyl triamine pentaacetic acid. Diethyl triamine pentaacetic acid. Then you have MAG3, which is a mercaptoacetyl triglycine. It's a mercaptoacetyl triglycine, which is the gold standard for renal perfusion. So DTPA is the investigational choice for renal perfusion. But if I say gold standard, if it is gold standard, If it is gold standard, then it has to be MAG3, that's a mercaptoacetyl triglycine, right? So this is in terms of nephrolithiasis. Management is going to be very simple. If it is less than or equal to 6 millimeters, conservative. 6 to 15 millimeters, ESWL. More than 15 millimeters, that is, if it is 15 to 20, you do ESWL with DJ. If it is going to be at a lower lying calyx stones, then you can do URSL or retrograde intrarenal surgery. If it is more than 20 millimeters, then you do PCNL. Staghorn calculi is going to be both ESWL. It's an ESWL with PCNL. If it fails, then you can open surgery. Again, don't go for a lot of details across here. You need to remember that the ESWL will require multiple settings. Whenever you're doing any procedures which requires a ureteric intervention, DJ stenting is must. URSL and RIRS, that is URSL is ureteroscopic lithotripsy or the retrograde intrarenal surgeries are done once the stone is getting stuck in the ureter or they are present in the lower lying calyxes, right? So lower lying calyceal stones you cannot access with URSL or RIRS, then you have to do PCNL, right? So the current indication for PCNL, size of the stone is more than 20 millimeters or if there is a lower calyx stone which is not going to drain out, or rather it is not going to be accessed by a URSL or RIRS. Genitourinary tuberculosis findings are very, very important from the exam perspective. In the kidney, what do you find? In the kidney, there will be autonephrectomy. If I say what is the earliest radiological feature? Earliest radiological feature. The earliest radiological feature for TB kidney. The earliest radiological feature of the TB kidney is, any idea? The answer is going to be fuzzy calyx. The fuzzy calyx appears like moth-eaten calyx. It is the moth-eaten calyx. In the bladder, around the ureteric orifice, it presents to you as golf hole ureter. It is a golf hole ureter. And in the bladder, it will present to you as thimble bladder. It will present as thimble bladder. For prostate, it will present to you as hard indurated prostate. For vas deferens, you will have beaded vas deferens. And for scrotum, there are multiple discharging. The multiple discharging scrotal sinus. There are multiple discharging scrotal sinus. So these are the features of genitourinary tuberculosis. Now talk about the congenital disorders of testes. Two important ones. One is your undescendant testes, another one is ectopic. Undescendant you will find in the normal embryonic path. Ectopic will neither be in scrotum nor in the normal embryonic path. The most common site for undescendant testes is going to be the inguinal canal. For ectopic testes, it is the superficial inguinal pouch. It is a superficial inguinal pouch. The status of the testes, they are poorly developed in undescendant testes. In ectopic, they are normal. Secondary sexual characters, if it is unilateral undescendant testes present, but if it's a bilateral undescendant testes, it is absent. Ectopic testes, it is normal. Spermatogenesis, if it is corrected beyond 1 year of life, it is lost. It is normal here. Scrotum is poorly developed. You can see the rugosities are lost, whereas the scrotum here is absolutely normal. Now for undescendant testes, if it is investigation is clinical examination, but if it is non-palpable, for non-palpable undescended testes, then it is your diagnostic laparoscopy. Same here also, it is going to be diagnostic laparoscopy, right? So there are two differentiating findings that you should know between the undescended testes and the ectopic testes. This is a spotter, you cannot miss this. This is your Fournier's gangrene. This is your Fournier's gangrene. Fournier's gangrene is the necrotizing. It is the necrotizing fasciitis. It is a necrotizing fasciitis of perineal region. It is polymicrobial and testes are spared. Management will be aggressive debridement. It is the aggressive debridement with antibiotics. With antibiotics is your Fournier's gangrene. Now, in the uro-radiology, the important images, the first one that you can see is a flower vase appearance. The flower vase appearance is seen in horseshoe kidney. The flower vase appearance is seen in horseshoe kidney. Now, in horseshoe kidney, the isthmus of the horseshoe kidney is seen between the third and the fourth lumbar vertebra. It is the third and the fourth lumbar vertebra, right? The ascent in the horseshoe kidney, the ascent is prevented. The ascent is prevented by inferior mesenteric artery. The ascent is prevented by inferior mesenteric artery. The second image you can see, this is your staghorn calculi. We have already discussed it. The staghorn calculi is your phosphate stones, or also called as triple stones. Now, what I want you to differentiate the staghorn calculi from this image. Now, this is what we call it as the putty kidney. Putty kidney is seen in renal tuberculosis. This is seen in renal tuberculosis. So, when you look at in the putty kidney, it is completely a mushed out kidney. There is no clear margins which are present. Whereas in staghorn calculi, you can actually make out the margins. They are more calcified and they're more organized, right? So if you have these margins cleared, if the margins are cleared, then I can say it is a staghorn calculi. But if there are no margins, if it is completely mushed out, this is what we call it as the putty kidney, which is seen in renal tuberculosis. Now, this image you can see is like a hook that is created. This is called as a fish hook ureter. This is what we call it as the fish hook ureter. And this fish hook ureter is what we see in retrocaval ureter, where the ureter is coming behind the IVC, and this is going to be associated with hydronephrosis. This is going to be associated with hydronephrosis. This is going to be associated with hydronephrosis. Now, this is your soap bubble sign. The soap bubble sign is seen in hydronephrosis. This is seen in hydronephrosis. This is your spider leg appearance. Now, the spider leg appearance is seen in polycystic kidney disease. In spider leg, basically, you can see this thinning of calyces. So, this thin calyx. Okay. So, spider leg appearance, the spider leg appearance is seen in polycystic kidney disease. Now this is about your entire urogenital system. Now basic surgical positions, your AIMS or your INI people love to ask you the generalized component. If the patient is put down in a straight position, it is called as supine. If there is head down and the entire body is faced like this, is called as prone position. Now, if I put the patient lateral and then split the table, this is called as lateral decubitus position, usually used for your thoracotomies and the renal surgeries. Your thoracotomy and the renal surgery. Right? Now, this is for the lithotomy position. This is your lithotomy position. So, in the lithotomy, you'll see the hip is going to be at 90 degrees and the knees are also going to be at 90 degrees, right? For all your perineal surgeries, your gynecological procedures, your endo-uro surgeries are done. Remember, the most common nerve injury in this position is the common peroneal nerve. Now, the prone position, if I split the table, this is what we call it as the jackknife position. The problem with jackknife position is it increases the risk for asphyxia. So risk for asphyxia increases in jackknife position. Now in the lithotomy position, because there was a lot of tension, so the Lloyd-Davis modified the lithotomy position called as the Lloyd-Davis position. In this, the hip is not flexed at 90 degrees, right? So you can see we have a hip at an angulation and this angulation is going to be kept at 30 degrees. Right? So the hip is going to be put at the 30 degrees, right? So hip flexion is going to be slightly wider and knees are also going to be slightly more wider here, right? We do a 15-degree head down and tilt and the hip flexion is at 30 degrees, right? So it is done for all endo-uro surgeries. Endo-uro surgeries, example like TURBT, TURP, all this. So transurethral resection of bladder tumor or transurethral resection of prostate, you would use Lloyd-Davis position. Now, if the head goes down, it is Trendelenburg. If head goes up, it is reverse Trendelenburg. So, supine position, these are the modifications. You put the head down, so the slanting, it's like a slanting position, but the head is pointing down, it is Trendelenburg. If the head goes up, it is a reverse Trendelenburg, right? Now, whenever you have risk for air embolism, which position would you use? Always reverse Trendelenburg. I want the air to rise up. For cranial surgeries, we use the Fowler's position. So Fowler's position is a sitting position for all your cranial surgeries or neurosurgeries rather. Rose position, we've been telling on top of our voice that the rose position or a barking dog position. The rogue position or barking dog position is usually done for neck surgeries, here for thyroid surgeries. Sims position is a midway between the prone and lateral, and this is done for digital rectal examination. So whenever you want to do a digital rectal examination or a per rectal examination, you have to go ahead with Sims position, right? Now, again, when you talk about, okay, all these positions are important. One second, guys. All right, so all these positions are important from the exam perspective. Be very clear about it, that what are the important aspects of it, and two important questions that they can ask you from the entire one. The difference between Trendelenburg, reverse Trendelenburg, that is also very commonly asked. Lloyd-Davis, they've asked you what is the modification and the, what is the most common problem that they can face across it. Jackknife, the risk for asphyxia is more, and lithotomy, the most common nerve injury is your common peroneal nerve, right? Now, when you talk about the surgical blades, now, when you talk about, when you want to give a stab incision, for a stab incision preferred is going to be a 11 number blade. For your IND, we'll prefer, again, you need to have a stab incision only. For IND also, we'll use a 11 number blade. If you're doing an arteriotomy, right? If you're doing an arteriotomy, you need a more precise incision. So we'll use 15 number. Remember, for IND, you can actually go with 11 number blade, which is a stab incision. More importantly, for suture removal, yeah, here I think, yeah, suture removal is given here. Suture removal is going to be 12. For your thoracotomy and laparotomy, we will use a size number 22. Now, Now this is the instrument which are important. Now this instrument is a needle holder. What is the name of this needle holder? See, needle holder will have a smaller jaw that is present. There will be presence of ratchet, right? Small jaw, ratchet is present. This is what we call it as the Mayo-Hagar needle holder. This is your Mayo-Hagar needle holder. It is the Mayo-Hagar needle holder. Now, when you want to suture smaller structure like vessels, I can't have such a big instrument. So then I will have this. This is called as Castroviejo needle holder. This is a spring action that is present here. So this is called as the Castroviejo needle holder. Now, when you look at the forceps, this is what we call it as the adsons. Adsons are the smaller version of the Gillies forceps, right? So this is your Gillies forceps. Both of them are tissue holding forceps. Gillies is longer. Adsons is going to be smaller. Now, if you can see in adsons, you will have, so adsons will have one end will have like this, the other end will have a projection. This is like this. So they both sit in each other. But if there is no locking mechanism here, this is called as Brown adsons. If it is avascular, I mean it is atraumatic, then it is your 𝐷-𝐄𝐝. There is no tooth, no jaw, it is 𝐷-𝐄𝐝. If it is curved in this manner, there is an adsons curved artery forceps. If there is no ratchet, you can say there is no ratchet, it's your sinus forceps. If it is like, if you look at the tip end of it, it appears as if the fingers are meeting with each other. This is called as Alice forceps. This is your Babcock to hold the bowel. It is an atraumatic bowel forceps. It is the atraumatic bowel forceps. It is your atraumatic bowel forceps. Then you have this triangulated ends which are present. If there is a triangulated end, this is what we call it as the dual lung holding forceps. It is a dual lung holding forceps. These are your dual lung holding forceps, right? This is a sponge holding forceps. How do you differentiate between sponge holding and an ovum holding forceps? For an ovum holding forceps, let it be straight or curved, there is no ratchet, right? That's the difference. For a sponge holding forceps, you will have a ratchet. For an ovum holding forceps, there is no ratchet. Ratchet is this locking factor that you have. Now, this is your Devas retractor, which is curved basically for all your large organs. Langenbach is a right angled retractor. Langenbach with a little bit of more wider and curvature, if you give, it becomes the Morris retractor. If you have one end Langenbach, other ends are two fangs, this is called as a Zernes retractor. This is what we call as a Zernes retractor. Now the same, you can see the Morris retractor, if it becomes more curvy, it is your Doyne's retractor. This is something that you have to recognize on seeing it. It is a Joll self-retaining retractor for thyroid surgeries. This is your mastoid for all your facial surgeries. Gallagher's is a self-retaining retractor. You have screws, you just put it for abdomen, it just splits open. Mayo curved scissors are a tissue cutting scissors that we use it. Now, your spotters in terms of the swellings, the first one is your sebaceous cyst. How do you know it's a sebaceous cyst? Always look for this black dot which is called as punctum. If the punctum over the summit of the swelling is present and the hair above the swelling is lost, if the hair above the swelling is lost, it is your sebaceous cyst. Lipoma, on the other hand, it is called as the universal tumor. It is called as the universal tumor. It is benign. If there is presence of multiple lipoma with pain, it is called as the Dercum's disease. This is called as the Dercum's disease. This is called as the Dercum's disease. In lipoma, the hair over the swelling is going to be present and the slip sign is going to be positive. Slip sign is when you're trying to palpate here and it will run away here. That is called a slip sign positive. If you see swelling at the fusion of the bones, that is called as the suture line, then it is going to be your angular dermoid. At the nape of the neck, if it is present on the posterior triangle, it is going to be cystic hygroma. The most common site is the posterior edge of the neck. It is due to the sequestration of the jugular sac. There is a positive transimulation and the sclerotherapy is the treatment of choice. If a baby is born with an abdominal wall defect with a covered membrane, if there is presence of membrane, If there is presence of membrane, it is omphalocele. And if the bowel is directly exposed, if there is bowel exposed, if the bowel is exposed, then it is called as gastrocesis. If the bowel is exposed, it is called as gastrocesis. This is what we call it as the sebaceous horn, and this is a very famous picture from Bailey and Love also. On the cover of the Bailey and Love, you will find this sebaceous horn. This is your venous ulcer. This is your venous ulcer. How do you know it is venous ulcer? Number one, it is present on the gaiters area. It is present on gaiters area. Number two, it is a shallow ulcer. It is shallow ulcer. It has sloping edge and there is pale scanty. This pale scanty, unhealthy granulation tissue. These are the characteristic of your venous ulcers. Now, if there's a tuft of hair on the back, it is a spina bifida occulta. A brilliant transillumination test positive is seen in two conditions. Number one is the hydrocele of the testes, and number two is going to be cystic hygroma. So, two conditions where the transillumination is going to be positive. One is the hydrocele of the testes, another one is going to be the cystic hygroma. Now, mesh placement has been our exam question. I've given you all the mesh placements. This we have already covered, omphalocele and gastrocesis. I will quickly review the mesh placement. Now, when you talk about the mesh placement, now in order to understand the mesh placement, let's say the outermost layer that you have, imagine that this is the skin that you have. Under the skin, you have the subcutaneous fat. Now, under the subcutaneous fat, you will have the muscles. So, this is your rectus abdominis muscle. So, this is the rectus abdominis muscle. This is your rectus abdominis muscle. Now, you see from the lateral side, you have the lateral muscles which are present. This is your external oblique muscle. This is your internal oblique muscle. This is your transverse abdominis muscle. The same orientation on the other side as well. Okay. Now, then you see there is fascia transversalis which is going to be present. So, let's say this happens to be the fascia transversalis. Below the level of fascia transversalis, you have the peritoneum. Between the fascia transversalis and the peritoneum, there is a preperitoneal pad of fat. So, this is a preperitoneal pad of fat. Now, you will notice the external oblique aponeurosis, the internal oblique aponeurosis, together they form the anterior rectus sheath. There is also the anterior rectus sheath. Again, the transverse abdominis, together they form the posterior rectus sheath. This is your posterior rectus sheath. Right. So, this is how the rectus sheath is formed. Right. So, if the anterior rectus sheath and the posterior rectus sheath. If I quickly label it down, right. So, let's say this happens to be the skin. Which is here. Under the skin, you have the subcutaneous fat, which is here. This is your external oblique muscle. This is your internal oblique muscle. This is your transverse abdominis muscle. This is your fascia transversalis. This is your peritoneum. This is your peritoneum that is present, and this is your preperitoneal fat. This is your preperitoneal pad of fat. This is your preperitoneal pad of fat. Okay. On the other hand, when you talk about the rectus sheath, this is your anterior rectus sheath. This happens to be the anterior rectus sheath. This is your anterior rectus sheath, and this happens to be your posterior rectus sheath. This is your posterior rectus sheath. Okay. So these are the whole components which are present. Now, when you talk about the mesh placements, right? Now, if I place the mesh under the subcutaneous fat, this is what we call it as on-lay mesh repair, right? If I place it between the two rectus abdominis, it is in-lay mesh repair. If it places on the posterior surface of the rectus abdominis, it is sublay. If I place between the rectus abdominis muscle and the posterior rectus sheath, it is retrorectus. And if I place it, okay, we'll use a different color to highlight these meshes. So this is your onlay, this is your inlay, this is your sublay, this is your retrorectus, and this is your IPOM. This is your IPOM. So these are the mesh placements on the ventral surfaces that are present, right? So the first one that you can see here, this is what we call it as onlay. This is what we call it as the onlay mesh repair. This is what we call it as inlay. This is what we call it as sublay. This is what we call it as retrorectus. This is what we call as retrorectus. And this is what we call it as IPOM. IPOM is intraperitoneal. It is an intraperitoneal on-lay mesh repair. Remember, whenever we talk about IPOM, this has to be only done by, it is only possible rather, by laparoscopic surgery. It is only possible by the laparoscopic surgery. It is only possible by laparoscopic surgery. So when I say onlay, it is under the subcutaneous fat. If I say inlay, it is between the two rectus abdominis muscle. If it is retrorectus, it is between the rectus abdominis muscle and the posterior rectus sheath. If it is sublay, it is between the posterior rectus sheath and the fascia transversalis. And if it is going to be IPOM, it is above the peritoneum and below the fascia transversalis, right? So this is all in all that you should know in the context of mesh placement. Okay? Chalo. This we already discussed it. If it is abdominal wall defect covered with membrane is omphalocele, or exposed bowel is going to be gastroschisis. Omphalocele will have a central abdominal wall defect, gastroschisis slightly on the right side. The defect of omphalocele is larger, more than 4 centimeters, whereas in gastroschisis is relatively smaller, around 4 centimeters. Two conditions which are associated with omphalocele is your Beckwith-Wiedemann syndrome and the cardiac abnormalities. The management is going to be same, reduce the content and repair the defects for both of them. So it has to be reduce the content and repair the defect. Whereas when you talk about it in terms of your gastroschisis, you have to put silo bag first. Silo bag is filled with, the silo bag will be filled with warm saline to prevent hypothermia and examine the bowel, and then obviously reduce the content and repair the defect. And repair the defect. Okay. So this is all in all that you should know with respect to our INI-CET marathon series. Okay. So we have covered most of the topics. I just want to do a quick recap of all this. This is going to be our revision material. Most of the questions should come from these topics, so I would want you to revise again. All right. Thank you so much for joining. If you have any questions, any queries, you can reach out to me personally also. That is on the Surgery Guy Instagram as well as Telegram, as well as on our PW Medit channel. Right. Thank you so much. Signing off. Take care.